Hi everyone, back to Pathology of the Liver. Welcome back to RAAONLINE. Today we'll see about inherited metabolic liver diseases. It's going to be a very interesting one with micronutrient abnormalities and being deposited, producing damage to the liver. We'll see about three diseases: hemochromatosis, Wilson disease and alpha-1 antitrypsin deficiency. First we'll see about hemochromatosis. Hemochromatosis. It is deposition of iron in the liver. This is healthy liver, iron deposition because of iron overload. This is healthy liver, this is hemochromatosis, producing certain specific abnormalities and histopathological features in the liver. Hemochromatosis, there is excessive iron absorption, and this excessively absorbed iron is deposited in main organs like liver and pancreas, which are the major things which can have specific findings in hemochromatosis. It also produces certain ill effects and damage to the heart, joints and endocrine organs. We have two types of hemochromatosis: hereditary and secondary. So hemochromatosis, hereditary hemochromatosis, there is mutations of genes encoding HFE, transferrin receptor 2 or hepcidin. Another type, mutations of genes encoding HJV, which is hemojuvelin, which produces juvenile hemochromatosis. Secondary hemochromatosis, it can be due to varied etiological factors. Parental iron overload due to red cell transfusions. For example, in hemolytic anemias like sickle cell disease or beta thalassemia, because of counteracting the effect of severe blood absence of RBCs because of increased destruction because of hemoglobinopathies, we transfuse the patients repeatedly for survival. That leads to iron overload. Or bone marrow failure, we give repeated iron transfusion, blood transfusions. Conditions with increased iron uptake, again beta thalassemia and myelodysplastic syndrome. Increased oral intake, yes, this is one quite interesting thing. In certain African countries, the persons, they cook in iron utensils and regularly, which causes increased secretion of iron in the food itself, that leads to iron overload, which goes by the name Bantu siderosis. Congenital atransferrinemia, again a receptor abnormality, and chronic liver diseases. Now, hereditary hemochromatosis, it very characteristically the mutation. If we ask for one etiology for hereditary hemochromatosis, I will opt for HFE mutations. There are certain others, but this is the most common one. And secondary iron overload, we have parenteral blood transfusions, iron dextran injections, ineffective erythropoiesis, thalassemia, sideroblastic anemia, I told, and increased intake in African countries, it's with Bantu siderosis. By clue, iron overload, it can be repeated blood transfusions, or hemochromatosis, which is hereditary, alimentary iron, liver disease like L, A for anemia like thalassemia, and S for other anemia, sideroblastic anemia, thalas. That is the clue or mnemonic for this. Now coming on to the pathogenesis of hemochromatosis. In genetic deficiency, 0.5 to 1 gram per year is the net iron accumulation. Clinical signs and symptoms occur if it is more than 20 grams of iron is accumulated in the body. Normal level of iron in the body is just 2 to 6 grams. The symptoms will be manifesting if it is more than 20 grams. And total body iron may be more than 50 grams even in case of severe hemochromatosis. Mechanism of liver injury, it produces lipid peroxidation, collagen formation, or the iron by itself or by production of the reactive oxygen species will cause direct DNA damage. So there is an increased risk of hepatocellular carcinoma with hemochromatosis. Hemochromatosis, increased risk of hepatocellular carcinoma is always there. So we'll see about the normal hemoglobin metabolism, iron metabolism. So normal, we have the plasma iron pool where iron, daily intake of iron, it's just going to be 1 to 2 milligram per day, and this goes to the liver, and it is used for, the iron is transported with the plasma protein transferrin, erythrocyte productions in the bone marrow, RBC production, then erythrocytes are released. These erythrocytes are destroyed by the macrophages in the spleen, and iron, it is coming to the plasma ion pool. In hemochromatosis, the iron inside itself is 3 to 5 grams, but the iron outside is the same, and this is responsible for increased iron pool. Iron pool is raised.